Thank
Dr.
you so
Fairooz.
much. Thank you for the kind introduction, sir. Always it's a pleasure to be here in Kerala. And well, presenting after my master is a tough task for me, but I will try my best. Thanks to Arshali, thanks to Dr. Arshid for having me here. It's an honor indeed and a privilege. And it's been a great topic that has been chosen. We often doesn't speak about it. And there's a lot of things that we also would like to share. In fact, when Arshali gave me this topic, there were so many cases that I really wanted to discuss. But then I had to pick few of those which can be purposeful and create an impact. And that's what I did, which can relate with everyone in day-to-day practice. So we're going to talk about missed clues, hard lessons, and unexpected outcome. These are my affiliations. I'm also associated with Malabar Cancer Center at Talsheri, where we have all the ocular oncology, treatment armamentarium that we had set up. I'm also associated with Amardeep, and I'm really happy to be associated with Kerala in this journey. So I'm going to take you through this particular case that we have recently published. So this is a 71-year-old gentleman. This is how he presented to us, with proptosis of the left eye. And as you can see here, there are nodules. All right, and there is extension of this large lesion sitting in the orbit, which is extending in the temporal fossa, and also there is bony erosion, almost extending into the brain. Now, this is a case of lacrimal gland myoepithelial carcinoma, X-pleomorphic adenoma with temporal fossa extension, and unfortunately, the patient has pulmonary metastasis as well. Could this have been avoided? Yes, of course. So the history dates back 7 years back when this patient presented with the proptosis. It was almost excised and it was a pleomorphic adenoma. Pleomorphic adenoma, to begin with, obviously it is a benign tumor. We all know that. It's not harmful to the patient will not die of it, the patient will not have metastasis, and there is no mortality associated with it. But if it is not treated well, this benign tumor can transform into a malignant, deadly tumor, and this is how the patient finally landed up. So whenever you have an orbital tumor which is very well defined and which is almost in favor clinically and radiologically of pleomorphic adenoma, solitary fibrous tumor, it is very, very important to excise it completely. It's not just go touch and come out. This is how it can transform. All right. So for the same reason, I'm going to start the next slide with a surgical video where I'm again going to show you how a pleomorphic adenoma can be completely excised from the orbit. This is a 15-year-old girl. As you can see here, there is a large lesion sitting in the temporal part. The lacrimal gland is involved. So although, as orbital surgeon, we try to take out the biggest tumor, we believe in micro-incision orbital surgery, like micro-incision cataract surgery and glaucoma surgeries. So this is a lid crease incision, but my ultimate goal, whatever it is to take the tumor completely out. So this is how we dissect with good exposure. So this is, skin orbicular is already done, going down. This is the periosteum that we go and incise here. You can see my periosteal elevator, which actually, borders the superior orbital rim. 4 millimeters above is where we actually elevate the periosteum. Slowly go forward. The periosteum is elevated. And then when the periosteum is completely elevated, you separate the periorbita very gently so that you don't breach anything there, especially the tumor and the capsule. Don't try to cut it because sometimes you can breach the capsule. And that is diffuse elevation with the lid guard. A small nick to open up the periorbita. And well, I don't do any bone excision or bone dissection, but this was a little bit tough because it was almost 42 millimeters, like a golf ball size. And this is a little bit of a nibbling of the bone that has been done. but make sure the entire tumor is out. So that thread is a lateral rectus over here, where we are checking whether there's no injury to the other structures in the orbit. And I try to avoid scissors. I want to make sure the capsule is intact, and I don't want any sharp instruments inside. Even if you have taken out the tumor completely, but you have breached the capsule, still there can be recurrence. Still it can transform into a malignant lesion. And well, complete excision. And this was the size of the tumor, 42 millimeters. And then you close the wound. And this is how it is. All right, so that is something that I really wanted to highlight. Dr. Sir has, Santosh Unavar has already highlighted this. I would just, want to say the treacherous malignancy of the orbit. Now you know the answer. It is adenoid cystic carcinoma. Why? Because the mortality rate is very, very high. All right, and the difficulty in managing this case when it reaches, any oculoplastic or orbital surgeon, even. Is that we have a very complex regional anatomy there, and there is a lack of effective treatment protocol. Sir has mentioned about it. I'm not going to go into detail, but I want to actually share some cases over here, sad cases, in fact. This is a patient from abroad, from Middle East, who was referred to my prosthetic center in Bangalore for exenteration prosthesis, starting from here, all right? Well, happy that I could give exenteration prosthesis, but was not too happy about the patient situation. I'll take you to the history, all right? This is how the patient landed in India, seeking for treatment for a proptosis of the left eye, okay? He landed up with a head and neck surgeon, all right? So the head and neck surgeon went ahead, exenteration, and that is to bicoronal, the entire flap was removed, exenteration was done, skin graft was put. He also underwent bilateral neck dissection, all right, to remove the lymph nodes, which was even not present in the PET scan, because this is a very, very rare cancer, all right, and it's the most lethal cancer of the orbit. I got my exposure to ACC when I was working with Sir, and he has seen enough and more. And the study that we published was starting from 1995. So I had the privilege to see these cases. So we have seen how many patients have died, and for the same reason, we have set certain protocol to salvage the life, the eye, and the vision. But this landed up like this. I don't have the next picture. In fact, he recently visited having tumor nodules in his scalp because of, it's not metastasis, it is a tumor infiltrate. When they were doing extensive surgery, the tumor has gone and sat in the skin. And this is how the patient progressed. Really, really sad, despite the fact that we have protocols in place, but then it is treated in a different way. This is yet another patient from Kerala, vision 6/12. Initially, lacrimal gland incision biopsy was done for the proptosis. Lacrimal gland ACC confirmed. The only thing that was given, despite most of the tumor sitting inside, was an orbit radiotherapy. All right? What happened? It progressed. Counting finger, half meter, entire orbit being filled with the tumor, and this has caused a very, very grave prognosis. So, would you do it different? Would I do it different if the patient initially came to me? Definitely yes. Definitely yes. Because I know it's a very treacherous and a lethal malignancy. And this is what I learned from my master, going through all the review of literature. And this is the study period from January 1995 to December 2015. And Sir has already discussed about the results. And we have found that multimodal treatment protocol can salvage the life, the eye without exenteration, and in most of the patients, the vision as well. So changing trend, multimodal treatment protocol is the in thing. It is definitely trending, and it is very, very important to be sensitive about these lesions in the orbit, all right? 44-year-old lady complaining of watering in the right eye, 2019, failed endoscopic DCR elsewhere, referred to me in my oculoplasty clinic for DCT, persistent watering. Now, this patient has said that she also has swelling since 2 months, diagnosed acrocystitis along with it, and, well, it's a case of a failed DCR. So, well, there is a lesion over here. She doesn't seem to have much of a discharge. First thing that I did was to do a RO+. RO+ was negative. Okay, dacryocystitis, usually RO+ is positive. There was hemolachremia. What would I do next? There is a lesion sitting there. Well, failed DCR, whatever. I just wanted to radiologically assess before I go ahead doing anything here, removing the sac. And this is what I found. So this is the area where the endoscopic DCR has been done. There is a trifoliate lesion over here, which is extending into the nasal cavity. And this was above the medial canthal tendon. So, well, went ahead, anterior orbitotomy, not a DCT, complete in toto excision biopsy, and of course DCT has to be done because it's involving the sac as well. And this is the medial canthal tendon that you see here, and this is the part of the tumor that is extending beyond. So this was the part which was extending into the nose, and this is the lesion which has been completely excised. You know what it came out as? Diffuse large B-cell lymphoma. All right. So, well, we have different ocular adnexal cell lymphoma. We have the low-grade extranodal marginal zone lymphoma, but DBLCL is the high-grade form of lymphoma. PET scan, luckily, was normal. She underwent R-CHOP. So, all epiphora is not always dacryocystitis. Whenever in doubt, you should always image it. This patient was referred to me way back for ptosis of the right eye. She does have ptosis. For ptosis surgery again in my oculoplasty clinic. But more than the ptosis, if it's an acquired ptosis, usually we get a high crease line. Okay, we get a high crease line. But this is a lower crease line. And you know what? There is some amount of fullness over there. All right, it's not sitting, it's not sounding right. Only thing I did was to do an imaging where I could find a lesion sitting, a small lesion, but still there is a lesion sitting there which is causing the ptosis in the patient. Went ahead, there's a superior oblique tendon over here. It's wrapping all around the superior oblique tendon, saved, took out the lesion. This is the immunohistochemistry panel that we do now in any lesion, all right? And this came out, well, staging was done, and this came out to be a T-cell lymphoma, follicular helper phenotype. PET scan, there was various lymph nodes involved. It was a systemic involvement. Bone marrow biopsy was positive in this patient, and it was a stage 4 lymphoma where the patient was initially diagnosed as a case of a ptosis. She underwent systemic chemotherapy, bone marrow transplantation, and orbital radiotherapy. So not all eyelid drooping is ptosis. Interesting case. On and off eyelid swelling in the right eye. Okay, puffiness, you can see here. The caruncle is kind of enlarged over here. Family history of malignancy. So the patient was hyper. She had this cancer, like fear, maybe something is happening in my eye. Well, I couldn't tell her that it could be cancer. Even I didn't think it could be cancer. All right. I was like, okay, there is something going wrong. And she has history of allergy. So all this while she has been treated as allergic rhinitis, allergic conjunctivitis. But allergy usually is bilateral. It can be asymmetric. It cannot be a unilateral allergy. So, well, this is a small swelling. I'm not sure whether it's even visible here in this picture because of the shadowing. We went ahead and we found this like jelly-like lesion which is sitting over the sac. And this is how it came out to be. And it was a nasal natural killer T-cell lymphoma, perisac extension, stage 2. In fact, natural killer T-cell lymphoma, midline granuloma, it's very a bad prognosis. She in fact succumbed to the disease with intestinal mets as well. So not every eyelid swelling is allergy. There can be more to it. So, you have to look it into the clinical details. This is a very interesting case. 12-year-old boy with proptosis of the left eye, 2 months. I saw him in November 2015. This was a lesson for me. This is external, extraocular motility was full. There was proptosis significant, 5 millimeter. This was how his fundus disc edema was, all right? A large lesion over here. So a 12-year-old boy with this large lesion, which is rapidly progressing, causing disc edema. My first diagnosis in my mind was rhabdomyosarcoma because that's the most common orbital tumor in childhood. Well, so in orbital rhabdomyosarcoma, as Sir said, we don't take too much of risk in damaging the vital structures in the orbit. So we kind of debulk it as much as possible. so that radiotherapy and chemotherapy can be done. I was overconfident. All right. Now, I send in for the biopsy immediately after I did the surgery because I was like, panicky that it's rhabdomyosarcoma. We have to start the treatment. I went in for a frozen section for the expedited diagnosis, and it came out to be a schwannoma neurilemoma, benign tumor. All right. Although I panicked for a malignancy. And then I was like, okay, I have left behind the tumor. This is definitely going to grow back. Now I have to go back and excise it again. I thought, okay, you know what? I'll observe because only a little part is remaining. I'll keep observing it because it's close to the optic nerve. In January 2016, he came back with the proptosis again. So there is a recurrence because it is schwannoma has to be excised completely. Otherwise, it will definitely recur. In fact, you have to take out the nerve also from the schwannoma is arising. So I went in for orbitotomy, complete excision biopsy left eye. It's repeat. And now this is what happened. He had an exotropia. I was 100% sure that I have not injured the muscle, And I'm like, okay, but then the motility is fine, but then he has an exotropia. Dr. Meenakshi is here. I'm happy you're here. All right, so then I went ahead and did a CT scan. So what I can see here is medial rectus because the tumor was so big that it has stretched the medial rectus and it was like really, really lax. And I have an excellent squint surgeon who works with me, Dr. Varsha. I was like, Varsha, red sign, I need your help, all right? And then she went and did the surgery. Ma'am, I'm really not sure what all she did. She dealt with many muscles and finally the child has 6/6 vision and orthotropic, yeah, right. So, well, a clinical radiological spectrum, and it's pretty rare in young children, schwannoma, and medial aspect is also pretty rare. So that is how I made a mistake over there. Ultimately, well, everything ended well. 35-year-old, simple case, redness, recurrence, subconjunctival hemorrhage, no pain, discharge discomfort. This is how the subconjunctival hemorrhage looked like. There is some kind of an orangish color over there. So what would you want to do? Most of you would just observe it, send the patient home, anything, audience. Sir, observe for a while. Yeah. Subconjunctival hemorrhage, we don't even have to, it just gonna resolve, right? Yeah. I went ahead did a surgery, sir, because it has been recurrent. Sometimes you can even have, a venolymphatic malformation there, lymphangiectasia over there, which can recurrently bleed. So I thought, you know what, why can't let me just go and take a biopsy. And that orange color was not something that was, sitting on well with subconjunctival hemorrhage. And this is amyloidosis. All right, so this came out as an amyloidosis. So it can have bad consequences as well. Luckily, this patient didn't have, including stiff heart syndrome, including, involving other organs in the body. And well, so this was a primary localized amyloidosis. We did the entire evaluation in her and she came out to be fine. So, well, this is the classification. I'm not going into the theory. Now, this case was actually excised elsewhere, referred to me for plaque brachytherapy, and in that histopathological report, it was diagnosed as squamous cell carcinoma of the conjunctiva. All right? It doesn't look like squamous cell carcinoma of the conjunctiva, so it was done in a local lab. Well, this is not how it looks. This doesn't look orange or pinkish. So this was also a case of an amyloidosis. I went ahead doing an biopsy, rebiopsying again, and that also came as a primary localized amyloidosis, although it was like really big, nodular. So these are the different presentations. So not all SCH is an SCH, okay? Now, this patient, can you make out something here? Right, left? Right eye? Right eye, left eye? Okay. Angle, lateral canthus, all right? Lateral canthus, not good. Okay, she has been treated with ointments, steroid, topical, eye drops, and she has been going around places, all right? I was not comfortable about this. So there is loss of lashes, although it's very, very, very focal and happening around the lid, around the meibomian gland. She didn't have an MGD in the other eye. Unilateral blepharitis, something like this, is definitely a caution, okay? So this was a case of a sebaceous gland carcinoma. Any asymmetric MGD or, blepharoconjunctivitis, you should always think of sebaceous gland carcinoma. or it can be even diffuse OSSN or a squamous cell carcinoma. Thank you very much for your patient listening.